One second. Okay, so here we are today. We are with Dr. Ahmed. We are going to discuss what it's like to become a physiatrist. Did I say it correct, Dr. Ahmed?
Physiatrist.
Physiatrist. Okay, it's a difficult word.
Okay.
So tell us a little bit about yourself, your background, and how you landed where you are today.
Okay. I am born and raised in New York. I trained, I went to college and med school in Long Island, New York, New York College of Osteopathic Medicine, which has now been renamed since then.
To New York College of Medicine, right? Isn't that correct?
No, it's the osteopathic school.
Osteopathic school, okay.
Yeah. I was like in the combined program with the bachelor's and then the DO, and then I ended up deciding to do residency in physiatry, and I ended up at NYU, and I did that, and then I did my intern year in Long Island, and then I did 3 years of residency at NYU, Rusk Rehab, and then I've been in private practice ever since.
So when you were in medical school, what attracted you to physiatry?
It was actually really, really random. A friend, I had actually applied pediatrics and anesthesia, and I wasn't even sure I liked either field. And a friend of mine who was kind of in the same boat, we were like just lost fourth years, not sure what the hell we were doing. And she was like, you might like this field, physiatry, go to NYU and do a rotation in it. And I literally did the rotation in November. At the end of that month, I did my exit interview, my residency interview, and matched at NYU.
It's very interesting. So most of the people listening who are medical students probably have never heard of physiatry as even an option.
Yeah.
What's the reason for that?
Because I had one class in it probably in med school. I mean, your bulk of your classes are anatomy, biochem, physiology. And then when you get to your second year, it's like, pathology and there's really no physiatry, like rehab. So you don't know what it is. And then you don't really, really know what it is until you get to third year and you're doing your internal medicine rotation and you're like discharging all these patients out of the inpatient unit. And you're like, send them to subacute. Well, or acute therapy, or where are they going? No one actually knows where they're going. Those are the physiatrists taking care of those patients that you're like, okay, they're off my service now. Goodbye. They must be getting better. But like the people who are rehabbing the patients, like after the neurologist sees them and they're like, oh, you've had a stroke. Okay, you're not an acute stroke. You're off my unit now.
You're with the physiatrist. But why do you think the medical schools haven't educated the medical students about physiatry?
Well, I mean, I am pretty old now, so
no, not even close. Not even close.
They might be doing a better job now than they are, but back when I was in med school, they really only had one class, maybe, and even then, I actually did like an elective with a physiatrist, and he was like a sports medicine doctor, because most people do physiatry to go into sports medicine. It's like acute backs, ankles, knees, shoulders, hip pain, and it's kind of like the ortho, but I'm not an ortho, but I can treat like hips and, all you're doing in physiatry is like muscles, nerves, and joints. But aside from sports medicine, there's a huge amount of other things you can do in your residency in physiatry. You learn like traumatic brain injuries when people have they're coming from the neurosurgery department, or strokes, like I said. There could be child rehab, so pediatric rehab. So that's like the kids who have cerebral palsy, or patients who've had post flu vaccine, transverse myelitis, or Guillain-Barré, and they end up in the pediatric rehab department. So there are a lot and there's like the veterans who have the PTSD and they need to see physiatrists for, cognitive rehab or behavioral therapy or occupational therapy. So there's a lot there, and I feel like when you're in med school, it's so much like surgery, medicine, peds, and okay, you don't really hear about a lot of the little fields. And so a lot of people just confuse it with psychiatry or physical therapy.
Well, that's why we're here today. We're here to educate people.
Yep, exactly.
But it sounds like you really get the gauntlet. You really get to treat patients who are, really young or really old and who go through all different types of medical issues.
Yeah,
and
sure.
I'm sure that's one of the attractions to the field, right?
Yeah, I mean, it's really, really different. Like when we were a class of like 14 or 15 people at NYU, and that's a lot of residents. And like I would say majority of them either go into, like, I think more than half went into sports medicine. Some go on to do pain management fellowships, and then they go into like more pain fields. And then there's the people who are like, I want to do cancer rehab, and I want to do pediatric rehab, and I want to do EMGs, like do an entire fellowship on EMGs. Like, I mean, whatever your cup of tea is, but like there's a lot of different ways and things that people can do. I mean, not a lot of people are like staying inpatient, but that doesn't mean that it's not your cup of tea. Like you might really enjoy that.
So what do you love about physiatry?
I was doing sports medicine for a while. I was,
so you were part of the half group who continued on to sports medicine, and you said, you know what, I'm going back to physiatry.
Well, so it's not really like you graduate residency and you're like, I'm gonna just do general basic outpatient sports medicine. So like knees and ankles and joints. Actually though, after I completed, there was no like extra fellowship for that. You're just kind of, if you want to do like spine procedures and that, then there would be more to fellowship for that. But I didn't want to do that. I was just kind of graduate. I want to work. I want to be an attending. And then after about 4 or 5 years of that, a colleague that I did my residency with, she actually, when she graduated, she wanted to do more women's physiatry, which wasn't really something we learned in residency. And so she was like, I've been doing all this women's stuff and I'm kind of just like doing it and I'm learning from other doctors. And she's like, would you want to learn about it too? And like join me. And then we could, and I was like, sure, I'm happy to, shadow you and see what you're doing. Cause I mean, I'm a woman. I think there's the need. And so
and there weren't enough doctors focused on pelvic oriented issues for physiatry at the time.
Yeah. Well, there still isn't. I would say in New York, there's only like 5 or 6 of us that are actually doing pelvic physiatry.
Wow.
Even still, like everyone thinks when I say I'm like a pelvic physiatrist, they're like, you probably just treat women. Well, actually, no, I treat about 40% male. And it's because there is a need for it. There's a huge amount of patients who have pelvic pain and it's unexplained, and they go to the urologist and they go to the GI doctor and they go to, they might go to their primary care and they're like, I have this tingling, or I have this sensation in my rectum or in my genitals and I don't know what it is. And, they get cultured and they get put on antibiotics and they're told that it might be a bacterial prostatitis. Like, we don't know. It's just, I don't know why it's bothering you. We've given you, we've done the workup. We can't figure it out. And so, turns out there's all those muscles that you see in your body, your neck, your arms, your legs, but there's a set of muscles underneath your bowel and your bladder and your prostate and or uterus, depending on the person. And those muscles can get tight and tense, just like your neck muscles and just like your quads and your hamstrings. So being a physiatrist, I examine hips, I examine knees, I examine ankles, and now I examine pelvic floors. And that's not something I thought I would ever do going into physiatry because I never really wanted to do rectals and vaginal exams, but now I'm here doing them because I can examine these muscles because a lot of like my patients, they go in and they're like, oh, I went to my GYN and she's like, says she says I'm okay and I don't have anything wrong with my uterus. I don't have anything wrong with my ovaries. But she's not examining the muscles, and it's only because she's not used to that. That's not her field.
Now, you went to an osteopathic school. I also went to an osteopathic school. It seems like you use some of your osteopathic skills right? Is that correct?
Yeah, because and some patients actually prefer seeing me because I'm an osteopath because of that total body approach, and we can kind of we use a lot of palpation, and we can, examine patients. And so people are like, I don't understand. Where have you guys been for the last 20 years? And we're like, we're figuring this out ourselves. Like, a lot of med students and residents have reached out asking if they could do rotations with us. And we're like, we're kind of like learning this also. And we're kind of just doing, it's very new and up and coming. And we're hoping that this will become like, a big field, and a lot of people will want to, and we're hoping to expand and teach more people and get into med schools and to get in. And mostly because if you get the education out there early, you can treat people earlier, and then they're not miserable.
Yeah, of course. And there needs to be more people in the field of physiatry. Can you give us a little insight, if you were a medical student now, looking back, and you wanted to prepare to be in the field?
Yeah.
Would you be doing, is there like certain research you should do? Obviously grades are important. How do you prepare? What residency programs do you apply to? Do you have to go through sports medicine?
Well, no, honestly, it's hard to say because actually a friend of mine's brother was like, or brother-in-law was looking into physiatry and was like, what exactly is it? And a lot of people are like, and I have to explain to them, like, you have to understand there's an inpatient and there's an outpatient, and they're very different. And so when you do a lot of rotations, you end up doing a lot of inpatient rotations. But if you were like, I want to do this, but I want to go out and do outpatient, then you should follow and shadow some outpatient doctors. Research-wise, you can always hop on anyone's. We have ongoing research all the time because of how new our field is. We're always trying to do a new study all the time.
Yeah, you're probably always discovering something new as well. That's undiscoverable. It hasn't been discovered yet.
Yeah, exactly. And so every day we're coming up with something new. And honestly, I think if you're really, really interested in doing PM&R, there's a lot of major academic centers in the East and in the West, and that have big, huge programs, and reaching out to them and trying to, because you might do an inpatient and be like, oh, I don't want to do this for, I don't want to do this for the rest of my life. But if you don't realize that half of us go outpatient, you're like, oh, wait, there is people don't necessarily, I would say sometimes people don't necessarily want to go into physiatry because of the inpatient, but most of us don't.
Inpatient meaning that they don't want to spend a lot of time in the hospital after their training?
After their training, they want to do an outpatient clinic. But the good thing about rehab is there's not a lot of call. There's not a lot of you're not. When you're in residency, yes, there's call, but not when you're an attending. There's no acute emergencies, because then they would be in ER. On another, or in a hospital, because the whole purpose is to try to rehab the body. So nothing is ever really acute.
I understand that. So tell us a little bit about what it was like for you to go through residency. What was the training? How many years was it?
So my internship I did out in Long Island. I just did a regular internship, and it was, I guess it wasn't a surgical one. It was part of a program that was had an FP residency. So it wasn't grueling or anything. I kind of did that on purpose because I didn't want to go through a grueling internship when I was not planning. And I knew I was going to have a harder second year. So my PGY 2 year, I was 2, 3, and 4. I was at NYU. The first year was, a lot of call, a lot of call, and that's. The good news, the thing that was a little tough about NYU is there was NYU Bellevue, there was Tisch, and there was the VA. So you're always split. So you're kind of hanging out with PGY 2s, 3s, and 4s. And the 4s, and you're just kind of looking up at the 4s, and you're like, I can't wait till I'm a 4 because you guys are just making us do all the work. And that's part of.
Is that the truth, or is that or as you get up, you actually get more responsibility?
You have more responsibility, but yeah, you do a lot less. I think so.
Well, the grass always looks greener on the other side of the fence, as they say.
It's true.
But maybe it does in this case.
But the call is actually a lot less when you're a PGY 4. I remember, I think we were doing like 5 calls a month, and I was like, this is crazy. You know, and then when you get to a PGY4 year, I actually had one of my daughters in PGY4, and I was actually like on a rotation. I remember, and I was on an elective, an EMG rotation, and, you know, I kind of just pretended I was there until the end, because I was like, I don't want to have to make up this day, even while I was in labor. It's like, oh yeah, I'm here. But like, you know, it gets way easier when you're the further along you are. But then the harder thing is figuring out what the heck you want to do like after residency, because I mean that's like a lifelong decision. You know?
But okay, so you've made that decision. You've navigated away from sports medicine. You're doing physiatry. I'm assuming you're very happy doing that now, right?
Well, no. So physiatry is like the big picture, and then there's sports medicine, and then from sports I'm doing pelvic. Pelvic, I'm very happy doing just pelvic pain, and you know, if I had wanted to do pain, just generalized pain, applying for fellowships, I would have had a more stressful residency, and I didn't do that because I didn't think I wanted to do pain. Ironically, now here I am doing pelvic pain, but I'm not doing a lot of the procedures that other pain specialists are doing. So in that sense, I'm not really doing pain. I'm doing like a modified pain. But, you know, I am happy doing what I'm doing. And, you know, you probably won't come across many pelvic physiatrists in your life, because, I mean, I don't know.
Well, we might change that today. It's possible.
Maybe that'll change.
So do you see an equal amount of women and men in the field?
I see, like patients?
No, in terms of doctors.
Oh no, it's more women.
More women. Do you hope that more men will enter the field as well? Or is it more geared for women? I'm just curious what your thoughts are on that particular.
I think it would be great for guys to get. It's a little bit of a sticky field because you don't really. I don't know how you see. Like, you know, I guess it's similar to like OBGYN. You know, I don't know if that's a mostly female field or not, but you have to do a lot of examinations on men and women, and obviously I'm examining men all the time, and you know, but not. I don't know. I haven't really seen a lot. I don't know any male pelvic physiatrists.
Okay, so what was the hardest part of your training?
The hardest part of training, it was just being a PGY2 and being intimidated.
So your second year was your hardest year with all the calls.
With all the calls and like being intimidated by the seniors and just having to work all the time. Okay.
Well, do you have any other advice for the medical students listening in terms of pursuing a career in physiatry?
I would say just try to reach out to other doctors. I mean, I think like a lot of people, I think like social media is pretty amazing in that sense. Like if you reach out to a doctor on social media and you're like, hey, can I shadow? You know, chances are they might say yes, and you can get a sense of what their day is like in a day or two. You don't need to do like a full, you know, month-long rotation. 'Cause, you know, those rotations should really be like kept for showcasing yourself for residency and trying to match. I feel like those, but before you even get to that point, you should probably shadow some doctors. And then this is for every field, to get a sense of every field. Of course.
Spend
like, you know, if you're a local, you want to be a pediatrician, spend 2 days with your pediatrician, like your own pediatrician, and see what it's like. And I really feel like that should start early. Like you should start that when you're an MS1, like right away, kind of figure out what field you want to go into.
MS1 meaning like a first-year medical student.
First-year med student.
Yeah.
You should, right away, you should kind of get knock some, you know, some fields off. So by the time you get to third year, you're not like, oh, what should I do? What should I be? Because I had no idea what I wanted. I thought I was like, oh, this is going to be in the bag. I'm going to be a pediatrician. And then I got there and I was like, these kids don't talk back. How am I going to know what's wrong with this kid? And I was like, I don't know if I want to do this. This is a lot of like guesswork. I can't. I was like, power to the pediatricians. I don't know how they do it.
But this is a great example. This is, you know, you're an example of someone who went into medical school and you said, you know what, I want to do pediatrics. And you did some rotations and you said, you know what, this is not for me. So really what you're encouraging people to do is do as many rotations as you can in medical school. It doesn't necessarily need to be a month long. It could be a day long. And that experience could really change the trajectory in terms of what career you end up eventually pursuing in terms of practicing.
I was, my fiance at the time was the anesthesiologist, so my current husband. And at that time, I was like, he applied it. I'm going to apply it. And I couldn't wake up. I was just not one of those people who wanted to wake up at 5 in the morning. And after like a month of it, I was like, I just applied to like 10 anesthesia programs. I wasted a lot of money, and now I don't want to do this field because I don't like being awake at 5 in the morning. And I'm still not a morning person. And so that's the great thing about physiatry. I have like a 9 to 5. And
what does your typical work week look like?
It's 9 to 5 every day. If I don't have a patient, I go in later. If I have a patient, it's whatever you want it to be when you're in outpatient. That's why a lot of people want to do outpatient, because you get to make your schedule. I'm a mom, but I still work full time. I don't set a lunch because a lot of times patients will cancel, and then I eat during my lunch when I have a cancellation.
So you have a lot of flexibility.
A lot of flexibility. I do some injections or procedures in a whole bunch in a row, and then sometimes I see new patients for like 3 days, 3 new patients in a row, and you get your work done, and then that's it. Come home and you don't have to worry about too much.
So it's a great work-life balance.
It is. It's a really great field that was like super. It's just started to get popular when I like graduated, and like right before I graduated, like no one really knew what it was. I think like over the last 10 years, it's kind of started to rise, but even still, I still think I'm constantly explaining what I do to people. On a regular.
Well, I want to thank you, Dr. Ahmed, for taking time out of your busy schedule. This was really informative, and I hope everyone listening got something taken away from this great interview. So thank you very much.
Thank you so much. I'm happy to answer any questions. If you ever have any questions about physiatry or pelvic rehab, I mean, it's a great field.
Okay, thank you so much.
All right, no problem. Take care. No.